Hello, everybody. Welcome to Ophthalmology Mastery Clinical Skills for MBBS students. Hello, everybody. In this video, we'll learn about examination of a cataract patient. Cataract case is a very common case that's kept for all of you in your exams, and you need to know what are the common questions that are asked, how you have to present your history, how you have to present your diagnosis, and the management of for every cataract case that is given to you. Now, so usually it will not be told that it's a cataract case. So usually it will be a reduced vision in elderly. So you will have to examine the patient for all these conditions and then rule out these conditions and then say it is a cataract case. So what are the common causes of reduced vision in elderly? It will be a refractive error, senile cataract, diabetic retinopathy, primary open angle glaucoma, and age related macular degeneration. So all these are causes of gradually progressive loss of vision. So any case that is given to you will be an elderly patient with gradually progressive loss of vision. So your history and examination should be such that you have to rule out all these causes and then pinpoint to a diagnosis of senile cataract. So the history obviously will be a gradually progressive loss of vision which is of insidious onset. So the differential diagnosis I've already said. What are the differential diagnoses for gradually progressive loss of vision? Corneal degenerations, primary open angle glaucoma, senile cataract, diabetic retinopathy, and age-related macular degeneration. So how does a patient with cataract present? They usually presents with hazy vision, where they say that the outline of the objects is not well seen, but is seen, but the clarity of the objects cannot be made. So they usually say, I mean, I can see, but it's not very sharp, right? They can also come to you, I mean, a posterior subcapsular cataract or in early stages of nuclear cortical cataract, they can present you with glare. That is, there is intolerance to ambient light, okay, or intolerance to bright light. So they say that everything appears, there's a starburst phenomenon or there's a glare when they see any light. They can also in early stages of senile cataract, senile immature cataract, they can also present with colored halos, where they say that they see a light and they see colored halos around the light. So these are the common symptoms that a patient with cataract presents with. Whenever they say glare, you have to differentiate from photophobia, and even when you present there is presence of glare, the question might be what is photophobia and how do you differentiate it. These are, I've highlighted these in the other videos, you can look at it. Colored halos, again, the differential diagnosis might be asked when you present it. Like you have to know acute mucopurulent conjunctivitis, corneal edema, and senile immature cataract. These are the causes of colored halos, and you have to know how to differentiate them too. Okay, so what is the associate history? So these should not be asked as leading questions, but when they're present, they should raise red flag if they're present in a patient. So loss of vision associated with pain. The patient says he has loss of vision and then he noticed pain. So if there was a gradually progressive loss of vision for many years and then the patient noticed pain, then it could be due to a complication of cataract, like a senile mature cataract became hypermature and then developed lens-induced glaucoma, phacomorphic or phacolytic glaucomas can present in this way, or loss of vision associated with pain. Okay, chronic iridocyclitis and herpetic keratitis can also present with pain, but this pain, please remember, it is intermittent pain. So the disease course itself goes on for many years. So there's an on and off pain, right, and associated with complicated cataract, and the patient has loss of vision. And loss of vision associated with redness, again, our differential diagnosis might be trauma. Acute onset of loss of vision redness might be trauma. But if it's a chronic one, the same signs, the same causes of loss of vision and pain, like chronic iridocyclitis and herpetic keratitis, might present with uveitis and present with complicated cataract and redness. So redness and pain might be there. Loss of vision, if the patient has associated watering, what could be the causes? Again, the causes could be a uveitis, so there's on and off episodic watering, but you would want to rule out watering in a case of loss of vision if you want to rule out dacryocystitis. So because the management might change if the patient has Chronic dacrocystitis also, you'd want to treat that first before you do the cataract surgery. So you need, whenever you ask or you write these, so a patient gives you a history of gradually progressive loss of vision, but you say there's no pain, redness or watering, you need to know what you're trying to rule out. So the examiner might ask you, why are you asking for redness, why are you asking for watering? So you need to know, I'm trying to rule out any other causes, or like chronic iridocyclitis or hepatic keratitis, or I also want to rule out chronic dacrocystitis, so, and please remember, do not give irrelevant history. Most of you try to add, when a patient presents with gradually progressive loss of vision, but you try to say there's no flashes and floaters of light. That is not right. Okay, so when a patient gives you a history of sudden loss of vision, yes, asking for floaters and flashes of light is relevant. But when a patient comes to you with gradually progressive loss of vision, none of your differential diagnosis is actually present with floaters and flashes of light. So it is irrelevant. You don't have to give those negative histories, right? So you will ask for any history of trauma. If there's an unequal asymmetric cataract on one side more than the other, you might want to ask history of trauma. The past history, you will ask for diabetes, hypertension, bronchial asthma. Again, diabetes, you're trying to rule out a diabetic retinopathy as a cause for gradually progressive loss of vision. Hypertension, you're trying to, I mean, if you're planning for surgery, you want to know if the patient BP is under control or patient is taking any medicines, so that you don't have any complications during cataract surgery. Bronchial asthma patients might be taking steroids, so you want to rule out corticosteroid induced glaucoma. Ophthalmic history, you will ask for any spectacle use, so trying to rule out refractive errors, right? Topical medications, like if the patient has been using topical medications for a long duration, for like in glaucoma or dry eye, you want to rule out those conditions. Or chronic iridocyclitis, on and off use of steroids, you want to rule out these conditions and pinpoint your diagnosis and narrow down the diagnosis to senile cataract. Personal history, sorry, so you will ask personal history, you will ask for um, diet, make tobacco use and all those things, and you will note them down for the completion of the history. Then coming to the examination, there are two things that you have to examine: general physical examination and ophthalmic examination. These are very important. Even though the examiners might tell you to go to the ophthalmic examination directly, but you still have to write them on your case sheet. Don't miss them. So you will write, make a note on the bill, nourishment, pulse, BP, and the systemic examination. Now coming to ophthalmic examination, we'll comment about the head posture, the facial symmetry. Okay, if there's any abnormalities that you see, like any ophthalmic case, you will mention all these things. Ocular symmetry, you will do the Hirschberg's corneal reflex test and mention whether it is orthotropic or not. Okay, then you will measure the visual acuity. It's very important. If Snellen's visual acuity chart is given to you in the exam, you will perform the Snellen's visual acuity test, and you will also mention the pinhole, if there's any improvement or not. So if there's on pinhole, if the vision improves, then you can directly rule out it is a refractive error. And on if it does not improve on pinhole, then you will have to be looking for organic causes, like cataract or any diabetic retinopathy or age-related macular degeneration, right? If you're not giving a Snellen's, if you have not given a Snellen's visual acuity chart, then you will do on bedside. You will say what is the counting fingers up till 6 meters. You can check on bedside. So until then, you will measure the visual acuity and then mention it on your case sheet. Near visual acuity, again use a Snellen's near vision and vision chart if it is given to you. So please remember, if the vision improves in pinhole test, then optical correction is an option. Even if it's a cataract, you're seeing a senile immature cataract, but the vision is improving on pinhole, you can still say optical correction. I will try optical correction, refraction and optical correction. If vision does not improve on pinhole, then surgical management will be the choice of your for your management when you try to tell the management. Okay, then you will write each eye separately. You will mention everything about the eyebrows, eyelids, lacrimal apparatus, conjunctiva and cornea. So please make sure that you write both right and left eye, and present right eye findings first. Don't say eyebrows right normal, left normal. First finish all the right eye examination and then go to the left eye examination. If you find something abnormal, you mention it. Otherwise, you're good to just say as normal and go to the next structure. Okay. Roplas, even though it's a cataract, not a water, the patient does not have water, you will still perform the Roplas test and mention Roplas negative. Roplas is regurgitation or pressure over lacrimal sac area, so you will mention it. Then anterior chamber depth, contents only if you find abnormality you'll mention, otherwise you'll say it as normal. And then iris and pupil you will mention. Now coming to lens, there you have to be extra careful. I mean, you have to mention the lens color. If it is a cortical cataract, you will say it will be, the color will be different. You will see it as grayish white. If it is senile immature cortical cataract, if it is pearly white, you'll say it is a senile mature cataract, and milky white you will call it as a senile hypermature cataract. Now, important thing, when you say grayish white, you will look for iris shadow and say iris shadow present, and that's why it is a senile immature cortical cataract. If it's pearly white and milky white, iris shadow will be absent. When you will, in this case, you will mention iris shadow absent. And please be sure, iris shadow is, you will mention in the lens examination and not in the iris examination, right? This is the Morgagni and the sclerotic cataracts, right? Now, nuclear cataract, grade 1 is yellow, grade 2 is amber, grade 3 is brown, and grade 4 is nearly black or red. So, the questions might be asked, what is cataracta brunescens? A brown cataract is a cataracta brunescens. Red cataract is called cataracta rubra, and black cataract is called cataracta nigra. A lens, you should also examine about the position, whether it's subluxated or dislocated or it's in normal position. So if it is subluxated, you will see the lens move downwards, you'll see the equator. This is subluxated down and out, subluxated down, up and out. Now this is dislocated into the anterior chamber. So you mention about the color, iris shadow, and then the position. If position is normal, just say position. We don't have to say it is normal. If it is abnormal, only mention where, if it is subluxated or dislocated. So again, please remember, when you the visual acuity should correlate with the color of the with your diagnosis. So if it's a senile immature cortical cataract, your vision should be between 618 to 660. Okay, but if you have a vision of hand movements and you have a senile immature cortical cataract, you should understand that the cataract does not explain the visual loss. So you're probably looking for something else along with cataract. Cataract might be there, but you're also looking for something else like diabetic retinopathy or age-related macular degeneration. And again, when you say senile mature cataract, don't try to say that the vision is 6:6 or 6:12. It will not be there. So you have to whatever you're mentioning in the vision, it has to correlate finally in the color of the lens and then finally in your diagnosis. So senile immature cortical cataract will have a visual acuity of 660 to 618, gray color, iris shadow will be present. Senile mature cataract vision will be between counting fingers 5 meters and hand movements, the pearly white, no iris shadow. Senile hypermature cataract, it will be vision will be probably PL positive and PR accurate, milky white, and no iris shadow again here. So this is, I've already told. So if the vision does not match, then you should suspect a posterior segment pathology. This video I will try to show the iris shadow. So if you throw light from the temporal side or nasal side, whichever side you throw, there will be iris shadow. The iris will be casting a shadow on the lens. So you will see it on the lens, right? So it is seen only in immature stage where you have clear fibers and opaque fibers. So light will pass through the clear fibers and fall on the opaque part of the lens. Right, so this is also the same thing where I'm trying to show the iris shadow, where you can, so remember, whichever side you throw the light, you'll see the iris shadow on that side. And please do not get confused with the eclipse sign when you're checking for the anterior chamber depth. You will not see that as iris shadow. Iris shadow is the shadow of the iris on the lens, right? So you have to remember, this is a mature cataract pearly white, and this is a milky white. This is a hyper mature cataract. This is a hyper mature cataract, where you see more ganglion where the lens is sunk down, and you'll see milky white cataract. This is after the lens, you will examine the tonometry. You will do a digital tonometry. You will perform, and then you will comment about whether the tension is normal. I mean, whether the globe is firm or not. Okay. Finally, once you've finished all the examination, you'll go on to your diagnosis. So you have to give these three things. You will mention the site, whether it's right or left, and you will mention whether it's senile, pre-senile, depending upon the age of the patient. Anything below 55, you'll mention it as pre-senile, above 55 senile. Whether it's a immature, mature, or hypermature stage, and whether it's a cortical or a nuclear cataract, depending on the whether it's a whitish or a yellowish color, right? So you will, once you finish all the diagnosis, all the examination of the right eye, you will say the diagnosis for right eye senile immature cortical cataract. After you finish all the examination of the left eye, you will say left eye senile immature cortical cataract, or senile mature cortical cataract. So that is your final diagnosis. Okay. You can have cataracts because of other causes. Traumatic cataract, where you see a rosette kind of cataract, which will help you identify the cause of the cataract, or congenital cataracts, depending upon the age of the patient, and you will see very distinctive morphological types of embryonic cataract or nuclear cataracts there. Diabetic cataract, snowflake cataracts, sunflower cataract, and Wilson's disease. These are distinctive morphological types where you have to identify the types of cataract. Right now, once you give the diagnosis, the next thing is management. You have to write down what are the investigations that you do and what is the management that you would want for your patient. Investigations ophthalmic would be if the vision is improving on pinhole, you will do diffraction and correct for refractive errors. You will check the intraocular pressure and rule out any glaucoma, right? Because that's also one of the cause for gradually progressive loss of vision. You will do a fundoscopy, ophthalmoscopy, to rule out diabetic retinopathy, age-related macular degeneration. So once you rule out all these things, then you know you are pinpointing your diagnosis to cataract. If it's a mature cataract, you're not able to see the fundus, you will do a B scan ultrasonography to make sure that the retina is normal. Once you do that, then the treatment is, if it is optical, is refraction. So refraction and correction, you give glasses, optical correction. Surgical, if there's no improvement of vision on pinhole, you will suggest a cataract surgery. So cataract surgery can be two types: small incision cataract surgery and phacoemulsification. Right? So if there's no improvement on visual acuity test, directly you will say my treatment of choice, my surgical will be surgical management. It's not only surgery, you will have to say small incision cataract surgery with a posterior chamber intraocular lens implantation, phacoemulsification with posterior chamber intraocular implantation. Then the next question that you will be asked is, so what is the pre-op investigation? So you have planned a surgery. What are the pre-op investigations that you would want to do? Systemic, yes, you want to do blood pressure and RBS to rule out hypertension, so that the blood pressure is controlled prior to surgery. RBS to make sure that the blood sugars are normal, and then because high blood sugars, the wound healing might be delayed. And we don't operate when the blood sugars are high, because the chance of infections are high and risk of endophthalmitis is high if the blood sugars are not under control. Ophthalmic preoperative investigations are, you will do a lacrimal syringing to rule out dacrocystitis, because that can lead to if you operate when a patient if you operate on cataract, when a patient has chronic dacrocystitis, the patient there's a risk of endophthalmitis. You will do biometry. What is biometry? It includes a scan to measure the axial length, and keratometry, that is to measure the corneal curvature. Okay, so using those two, you will do the using the SRK formula, you will measure the intraocular lens power, which is P is equal to A minus 2.5 L minus 0.9 K, where L is the axial length and K is the keratometry, and A is a constant for each lens. Okay, you will probably do a macular function test to rule out to prognosticate with the whether the patient will improve with vision or not. right? What are the types of cataract? The next question that will be asked, what are the types of cataract surgery? It could be an intracapsular or an extracapsular cataract extraction. Intracapsular, where the lens along with the whole bag is removed, whereas extracapsular, only the posterior capsule is left behind and only the nucleus is removed. These are so small incision cataract surgery and phacoemulsification cataract surgery are part of the types of extracapsular cataract extraction. You also need to know about the post-operative care. So usually we give steroid eye drops are given for 4 to 6 weeks in a tapering dose. Prednisolone acetate 1% or dexamethasone 0.1%. Topical antibiotics broad spectrum will be given for 1 week starting on the day of surgery. What is the schedule for follow-up visit? First day, third day, first week, and then 1 month. You will tell the patient not to rub the eyes. Report immediately in case of any redness, pain, reduced vision. Other eye drops, if there's a post-operative raised intraocular pressure or corneal edema, you will give the anti-glaucoma medications or corneal anti-edema measures for reducing the corneal edema. So in summary, you will have to give a complete history, do a complete examination, and give a proper diagnosis. Okay, the examiners are looking at whether you're eliminating the differential diagnosis for gradually progressive loss of vision and then arriving at the diagnosis of cortical cataract or nuclear cataract. Investigations, please remember systemic to rule out diabetes and hypertension and ophthalmic for lacrimal syringing and biometry. These are important. Management, write it on your case sheets, don't miss it, and you need to know the differences between SIC, small incision cataract surgery, and phacoemulsification. A post-operative management of an uneventful cataract surgery. What could be the intra-op and post-op complications, and their management also can be asked, right? So this is the presentation of cataract case, and you have to know at least the basic these things you have to know, but the questions can be anything about cataract and the cataract surgery or even intraocular lenses can be asked. Thank you very much.